The Falcon Review for Pathology for USMLE Step 1. The topic for this section will be lower urinary tract pathology. As with many of these sections, we're going to deal predominantly with conditions such as tumors and infections that affect the lower urinary tract, both in males and females. There will, however, be some conditions that preferentially affect men versus women, and certain tumors in here where there's a significant environmental component. These are clues that you should look for when you're reading through the beginning of problems for USMLE Step 1. We'll begin by looking at tumors and other conditions that affect the ureters. There are some benign tumors that affect the ureters, such as fibroepithelial polyps. These are lesions that present as a small mass projecting into the lumen and produce clinically a picture of obstruction and potentially UTI-type symptoms within a patient. One can also see smooth muscle tumors that one might see elsewhere in the body, such as leiomyomas. There are, however, various malignant tumors that affect the ureter and urinary bladder. These include transitional cell carcinoma, which is one of the most frequent and one of the most deadly. Again, like the fibroepithelial polyp, this tumor can cause obstruction of the ureteral lumen and lead to symptoms that one would associate with the incomplete passage of urine and buildup of urine within the kidney and bladder, so one will see symptoms and signs of something such as a urinary tract infection. Think about transitional cell carcinoma in older patients, those generally in the 6th to 7th decade of life. We'll begin by looking at tumors and other conditions that affect the ureters. This slide merely shows an example of a transitional cell carcinoma that has grown to expand and nearly completely block the entire lumen of the ureter involved. For the bladder, there are various conditions that can lead to adverse effects for the patient, including the development of diverticuli. Just as one can have diverticuli in other organs that are surrounded by muscular walls, such as in the lower GI tract, one can see these within the bladder as well, given the surrounding muscle wall that envelops the bladder. Just as in the lower GI system, when we refer to a diverticuli, we are referring to a pouch-like eversion or evagination of the bladder wall. These can be congenital due to a focal area where there is failure to development of the normal musculature, or these can be acquired as well. Think about acquired diverticuli in patients who for some reason have an abnormal buildup of pressure within their lower urinary tract. The most common condition that could lead to this would be seen in men who, if affected with benign prostatic hypertrophy, which we will discuss later in our section on the male reproductive system, can have a buildup of urine within the bladder, which they are unable to pass out effectively due to the compression of the bladder around the urinary tract, and thus with the increase of pressure within the bladder, have the development of secondary diverticuli. The problem with diverticuli is they are an area where there is the possible stasis of urine and hence the development of infection, and then obviously there is also the possibility that the diverticuli themselves may burst and leak. One can see within children, in particular, vesicoureteral reflux, where there is the expression of urine backwards within the urinary tract, potentially up into the kidney. This, naturally enough, can be a very serious condition which leads to renal infection and scarring. This slide merely demonstrates a classic bladder diverticulum. You see the lumen of the bladder demonstrated by the letter L. The bladder has been opened along the top of its surface, and you see the diverticuli, which has also been opened and which is demonstrated by the small black arrow. Note the outpouching within the bladder wall, most likely an area where there was a defect in the musculature, and hence the bladder wall could begin to push through this weakness in the muscle and create this diverticuli. Congenital abnormalities that can affect the lower urinary tract include congenital vesicoureteral fistulas. This is any sort of abnormal connection between the bladder and other organs, such as the vagina, the rectum, or uterus. Also, urachal remnants. A fistulous urinary tract between the bladder and the umbilicus. This is something that can serve as a focus for infection, or in older individuals, if this is present, can lead to the development of carcinoma in this area, particularly the development of adenocarcinoma. Infections of the bladder are referred to under the generic term cystitis, and what one has to remember is that there are various etiologies that you have to keep in mind for a patient who has developed signs and symptoms of cystitis that will often mimic those of a UTI. There are numerous common bacterial etiologies which you can discern often only with the use of a culture of the patient's urine. You want to think about organisms such as E. coli, Proteus, Klebsiella, and Enterobacter. However, there are other non-bacterial forms of cystitis, and you must consider things such as hemorrhagic cystitis, possible radiation injury, particularly in patients who've been treated for things such as prostate cancer, or patients on a particular form of chemotherapy for tumors elsewhere in the body can develop cystitis. So there are a few viral causes, including adenovirus, and one can have the development of a suppurative cystitis with continued inflammation, or eventually a chronic cystitis picture. What one sees clinically within these patients, perhaps the most common complaint, is one of frequency. The need to constantly urinate, even if one is only passing out a few cc's of urine with each trip to the bathroom. Some patients may complain of lower abdominal pain, which not surprisingly is going to be localized over the bladder or suprapubic region, and some patients will also complain of dysuria, pain, or burning sensation upon urinating. There are a few particular forms of cystitis that are worth knowing about in preparation for USMLE Step 1. Interstitial cystitis, or as it's referred to sometimes as Hunter's ulcer, is a particular form of chronic cystitis that is often seen in women. It is painful, and these patients present with the same signs and symptoms of a patient affected with a bacterial cystitis, but here one is unable to culture the offending organism. Another form of cystitis that's worth knowing about for USMLE Step 1 is a condition known as malakoplakia. First of all, be aware that this word can be spelled two different ways. One can see it spelled with a C, as we've represented it here in the slide. In other textbooks and on exams, it can be spelled with a K. Don't be surprised, it's the same disorder. This is an inflammatory reaction characterized, if one were to look at the bladder grossly, by soft, yellow, slightly raised mucosal plaques, 3 to 4 centimeters in diameter. There's also a classic histologic finding, or microscopic finding with this condition, the presence of what are called Michaelis-Gutmann bodies. Michaelis-Gutmann bodies are simply foamy histiocytes containing incompletely digested bacteria. The bacteria here are often things such as E. coli or Proteus, which create a chronic bacterial infection, which leads to the macroscopic and microscopic findings that characterize malakoplakia. That concludes inflammatory conditions of the bladder. We now move on to tumors. Again, as in the ureter, the primary culprit here is going to be, not surprisingly, given the epithelium of the bladder and ureters, transitional cell carcinomas. The transitional cell carcinomas, like tumors elsewhere in the body, can occupy a variety of grades. Lower grade tumors often are referred to simply as papillomas or papillary transitional cell carcinomas. These are considered often non-invasive, but are prone to frequent recurrences. Hence, these will be, again, predominantly elderly patients. Remember, we're looking at patients in probably the 6th to 7th decade of life, where they need to undergo frequent scopes in the clinic to find small little papillary tumors within the bladder that can be resected. The patient will then be free of tumor for a while and then undergo another scope within a year to find yet other small little papillary tumors that are at that time non-invasive, but which still need to be removed. High-grade urothelial carcinomas share similar features to other high-grade tumors elsewhere in the body. That is, you will see cellular pleomorphism and anaplasia, large atypical cells, often with high nuclear cytoplasmic ratios, bizarre cellular shapes, and bizarre nuclear shapes. The concern here is that these tumors are invasive and have the potential to metastases. Flat tumors will often generally be considered automatically to be high-grade transitional cell carcinomas. This slide simply shows an example of the normal transitional cell bladder mucosa. Note the ordered collection of cells, somewhere between 5 to 7 cells thick in terms of the number of cell layers. Note the nuclear cytoplasmic ratio is essentially consistent across the cells and different layers of the cells, and that there is very little in terms of changes in the overall histology to the different cell types. That is, there is very little anaplasia, nuclear pleomorphism, or the such. This next slide gives an example of what would probably be a low-grade papilloma or low-grade transitional cell carcinoma of the bladder. Note, first of all, the change from our previous picture that one no longer has the nice, flat, cohesive, orderly appearance of the transitional cell mucosa. Instead, you have the fronds and finger-like papillae of the papilloma. Note also the cells appear darker and more anaplastic. The very large, dark, smudgy cells in there may be mitoses, something which we did not see with great frequency in our previous slide. Also note the increased nuclear cytoplasmic ratio and overall cellular anaplasia compared to our previous slide of the normal bladder mucosa. There are other tumors that can affect the bladder, although they tend to be rarer than transitional cell carcinoma. One can see squamous cell carcinomas and adenocarcinomas. Again, as we mentioned earlier, think of the adenocarcinomas occurring in the urachus or urachal remnants. Squamous cell carcinomas, when one sees these, one will want to think about various risk factors in patients. So think about patients who have an extensive smoking history or have worked in an industry where they were exposed to chemicals such as arylamines. Also think about squamous cell carcinomas in regions of the world where exposure to parasites such as schistosoma hematobium are commonplace. And finally, think about patients who've had long-term exposure to cyclophosphamide. Again, the clinical presentation here will be similar to what one might see with transitional cell carcinoma, painless hematuria. That concludes tumors that affect the mucosal surface of the bladder. Remember, however, that the bladder is surrounded by a muscular wall, and hence there are various mesenchymal tumors that can affect the bladder as well. The most common of these, not surprisingly, is the benign tumor leiomyoma. Remember, we could see leiomyomas within the ureters as well. Sarcomas are rare, but when they are present, they tend to produce large masses that will protrude into the lumen of the bladder. And one can also see muscular tumors such as rhabdomyosarcoma. That concludes this section of the Falcon Pathology Review for USMLE Step 1, the topic being the lower urinary.